All right. Welcome everyone to our weekly webinar organized by College of Physicians Malaysia. So our theme of the month is rheumatology, and we are very fortunate to have with us as our chairperson, Dr. Asma Mohamad. A few words on Dr. Asma. She graduated from Royal College of Surgery, Ireland, obtained her master's in internal medicine from University Malaya, and completed her fellowship in rheumatology in Hospital Tuanku Jaafar Seremban, as well as Tan Tock Seng Hospital in Singapore. She has been a rheumatologist since 2009 and is the head of a medical department in HTJS. She's a principal investigator for numerous studies, as well as she has organized workshops and symposiums pertaining to rheumatology. She's also a member of the CPG development group for rheumatoid arthritis, gout, as well as post-basic rheumatology curriculum. She's the past president of Malaysia Society of Rheumatology, as well as president of the Pertubuhan Arthritis Negeri Sembilan. She's actively involved in patient advocacy programs. Without further ado, let us welcome Dr. Asma.
Hi, Bismillahirrahmanirrahim. Assalamualaikum. Very good afternoon. Thank you, Mr. Chairperson, Dr. Kelvin. Good afternoon, everyone. I'm Dr. Asma, as mentioned. I'm a consultant rheumatologist from Hospital Tuanku Jaafar Seremban. Welcome to College of Physicians of Malaysia's medical webinar. And the month of August is dedicated to rheumatology. To kick off this August webinar, we have Dr. Chok Leh Hock, who will present today's topic entitled Recognizing and Managing Inflammatory Arthritis. Managing inflammatory myositis in daily practice. There are lots of developments in the field of idiopathic inflammatory myositis over the last decades or so, in its diagnosis, its classification, and its associated problems. And with that, it can be recognized early, and it will dictate different therapeutic modes to prevent further progression as well as complication. So a bit of an introduction. Dr. Chok is a physician and rheumatologist currently working in Hospital Tuanku Jaafar Seremban. He received his first degree in University Malaysia Sarawak in 2013, conferred from MRCP UK in 2017. Subsequently, he became a fellow in rheumatology in two centres, Sarawak GH and Hospital Tuanku Jaafar Seremban, and he completed his training in early 2025. Over the last 6 years or so, Dr. Chok has involved in multiple industry-sponsored researches, as well as investigator-initiated researches, and has had study and poster presentations in multiple platforms, and still actively having ongoing research activities. Okay, ladies and gentlemen, let's listen to Dr. Chok, and we shall address any questions after the talk. Keep posting the question if you have any in the chat box or the Q&A box, yeah? Okay, Dr. Chok, the platform is yours. Thank you.
Okay, good afternoon, everyone. I'm Dr. Chok, here. Thank you, Dr. Asma, for the kind introduction. Okay, and thank you, College of Physicians, for inviting to present on this webinar series. So I'll start sharing my slide. Just to check, you all can see my slide, right? You all can see my slide?
No, wait.
Hold on. Not yet.
Not yet.
Lehot, not yet, yeah.
Not yet, okay.
Wait,
Let
hold
me
on.
do it again, huh? Okay, so can you all see now?
Yeah.
Yes, it helped. Carry on.
Yes, okay. Yes. Yeah, so my topic today will be recognizing and managing inflammatory myositis in daily practice. So my contents of presentation today include introduction, classification criteria, the myositis antibodies, the principle of management, and at the end we have the 3 real cases illustration at the end of the presentations. So what is this inflammatory? I just need to share my slide. Just need to, yeah. Okay. Yeah, so what do we mean by idiopathic inflammatory myopathy? Okay, it's actually a idiopathic, actually a heterogeneous group of the autoimmune diseases characterized by chronic inflammation of the muscle, leading to muscle weakness and often involving other organs such as the skin, lungs, and joint. So the estimated prevalence of myositis is about 5 to 22 per 100,000 persons. And also the incidence is approximately 0.12 to 1.9 per 100,000 person years. The overall female to male incidence ratio is about 2 to 3 is to 1. It's more common in female. So next, how do we classify myositis? Yeah, so this diagram actually summarizes the history of how do we classify the myositis. So the very first classification criteria is done by the Peter and Bohan, I think 1975. I think most of us are familiar with this. Then throughout the years, okay, there's a lot of development in terms of how do we classify the inflammatory myositis. And together with this, the identification and also discovery of a lot of new myositis-associated antibodies. Okay, so I think then subsequently we have all these classification by the European Neuromuscular Center classification, and also in our rheumatology fraternity, the one we are more familiar with and the one we are using is the EULAR-SCR 2017 classification criteria. So with the advancement in the muscle imaging and also all these serological profiling, so our classification criteria has actually moved on to more to the serological profiling and also the clinical seropathological orientated. Yeah, so this slide actually tell us about the sensitivity and specificity of the different classification criteria. So from here, you can actually see that from the very first classification criteria, the classification is simple. It's just classified, if there's a presence of rash, we classify it as a dermatomyositis. Okay, and let's say there's a muscle involvement, but there's no rash, we classify as a polymyositis, as simple as that. But subsequently, with the newer classification criteria, there's more subgroup identified, okay, where actually we classified under this EULAR-SCR 2017 classification criteria. We classify it as a dermatomyositis, polymyositis, amyopathic dermatomyositis, juvenile dermatomyositis, and also inclusion body myositis. So first, we'll look at this criteria. Okay, the Peter and Bohan classification criteria 1975. Okay, so from here, there are 5 components. Okay, so from this classification criteria, we also can know what are the usual presentation of the myositis. Okay, where the first component is a symmetrical weakness, usually progressive, of the limb girdle, muscle with or without dysphagia and respiratory muscle weakness. Second component is a abnormal muscle biopsy. And thirdly is the elevation of the muscle enzyme. Fourth one is the abnormal EMG. And fifth one is the characteristic rashes of the dermatomyositis. So from this classification criteria, if let's say we have all the first 4 components, okay, we can classify the patient to have definite polymyositis. If let's say patient has 3 out of the first 4 components, together with the characteristic rashes, okay, we can also classify the patient to have definite dermatomyositis. So what are the characteristic features or classical cutaneous manifestation of dermatomyositis? Okay, so first we have this, we'll go through one by one. So first we have this heliotrope rash. Heliotrope rash is actually described as a reddish purple rash on the upper eyelids, accompanied by swelling of the eyelids. Okay, then the next one is the Gotham papules. Gotham papules is actually very pathognomonic rash in the dermatomyositis, where it's described as a erythematous papulosquamous eruption over the dorsal surfaces of the knuckles. Okay, so yeah, we also get this Gotton sign. Okay, but the difference between Gotton papule and the Gotton sign is just that for the papules they are raised vision, and then for the sign the vision usually is not raised. We also have this periangle abnormalities, okay, where we can find abnormalities at over the periangle region. Okay, we can have erythema, dilated capillary lobes, or cuticular hemorrhages over the periangle region. So next will be the show sign and V sign. So poikiloderma actually is a area of skin with hyperpigmentation together with atrophy and telangiectasis. If let's say this happened over the posterior part, we call it a show sign. If let's say this happened over the anterior upper chest, we call it a V sign. And next we have also this Holster sign. Holster sign actually violaces erythemated rashes on the lateral aspect of the hips and also the upper thighs. Yeah, these are all the classical skin lesion that we will see in dermatomyositis. So for those who are practicing at the front line, those who are working in the district, if you see all these characteristic rashes, okay, have a high index of suspicious of the inflammatory myositis. Yeah, so next we'll go to this 2017 EULAR SER classification criteria. Yeah, so yeah, this classification criteria actually involves scoring of different components. Okay, so yeah, so it will be based on first it will be based on the onset of the disease. Okay, and also secondly, on the symptoms, muscle weakness. The muscle involvement in myositis usually involve more the proximal muscle compared to the distal muscle. And for the neck muscle, usually the neck flexor are usually involved more compared to the neck extensors. For skin manifestation, the typical rashes I mentioned just now. Other clinical manifestation include dysphagia or esophageal dysmotility. Laboratory investigation include the myositis antibody, the anti-JOA antibody, and also the elevated muscle enzyme. Then lastly, we have this abnormal muscle biopsy. Okay, so from here, you can actually see that there are components for scoring for the when there's no biopsy done, and also the scoring with the where the biopsy was done. Okay, so from here you can actually see that muscle biopsy actually not necessary or not compulsory. Okay, in making the diagnosis of the inflammatory myositis in the case where we have the typical features and also with the positive myositis antibody. So after we have all this information, okay, then and go through all these components. So if the score is more than equals to 7.5 without muscle biopsy, or the score is more than equals to 8.7 with muscle biopsy, we can classify the patient to have definite inflammatory myositis. Yeah, so after we have made the confidently make the diagnosis of the inflammatory myositis, this from this classification classification criteria, okay, they come up with this diagram also to help us how to sub-classify the inflammatory myositis. So first we look at the onset of the disease. If let's say the age of onset is less than 18 years old, so you go to this pathway. If let's say there's a presence of typical rash, okay, then we can classify it as a juvenile dermatomyositis. If let's say without the typical rash, it will go under other juvenile myositis. So so it is adult onset if the age of onset is more than 18 years old. So if let's say patient has typical rashes and also muscle involvement, we'll classify it as a dermatomyositis. If let's say got rash, but there's actually no or very subclinical muscle involvement, we classify it as a amyopathic dermatomyositis. Okay, so if let's say we have there's no rash, but there's muscle involvement, we classify under polymyositis. Okay, so just to mention that the immune-mediated necrotizing myositis, the IMNM, is actually under this polymyositis. Okay, and if let's say there is some special features, for example, there is a very prominent finger flexor weakness, is not is not response to the treatment, and when there is a rim vacuole on the muscle biopsy, we classify it under the special type of the myositis, which is our inclusion body myositis. Okay, so next, I would like to talk about this myositis antibody. So myositis antibody actually it can be divided into mainly into two types. Okay, myositis-specific antibodies. As the name implies, specific means that it's only detected in myositis patient and not in other autoimmune condition. Usually, MSA are usually considered as a mutually exclusive, and usually one MSA will be observed in a single patient. Whereas for these myositis-associated antibodies, okay, they can be detected in myositis patient, but also in other autoimmune conditions, for example, scleroderma, and etc. One or several MAA may be observed in a single myositis patient. Okay, and the autoantibody, all these autoantibodies are observed in up to 80 to 90% of myositis patients. Yeah, so what are the example of the myositis specific autoantibody? Okay, these are all the example of the myositis specific autoantibody. For example, our anti-Me2, anti-OJ, EJ, anti-TIF, anti-JOA, etc. Okay, whereas for the myositis associated autoantibody, we have anti-PL, PMSCL75, anti-CoO, anti-Ro50. All these are example of the myositis-associated autoantibody. So these are the result we'll get if we send our myositis profile to the private, and these are the result that we'll get, or the antibodies that they are tested if we send our myositis panel to the government lab. Yeah, so I like this diagram very much. Okay, so this diagram nicely summarize the association of the different myositis antibody with its symptoms and also syndrome. So, for example, for under this anti-synthetase syndrome, okay, the associated autoantibodies include anti-JO1, anti-EJ, OJ, PL7, PL12. Okay, all these are called anti-synthetase antibodies. So MTPM, SCL, MT-CoO, anti-Ro, all these are associated with the OLED syndromes. And anti-NSP2, anti-TIF1, they are highly associated with malignancy. And MD and DFI, usually they are associated with severe progressive ILD. And anti-CN1A is usually associated with the inclusion body myositis. For necrotizing myositis, the associated antibodies are anti-SRP and also the anti-HMG CoA reductase. So from with the autoantibody profile, it can actually tell us what symptoms or what syndrome they are associated with, okay, to help us with the diagnosis and also the predicting the phenotypes. Yeah, so next, this slide is what the importance of myositis antibody, as I mentioned just now, all the antibodies. So according to the British guideline, the BSR guideline, all these antibody can help us with the diagnosis. Because as I mentioned before, all these antibodies are included in the classification criteria for the myositis. Okay, second, it carries different phenotypes. So for example, just now the anti-synthetase antibody associated with anti-synthetase syndrome. And thirdly, you help us to tailor our treatment. For example, those with anti-Me2 positive, usually they are very responsive to steroid treatment and they are easy to treat. So lastly is for the prognostication. So example, those who who are anti-MDA5 positive, they are associated with severe progressive lung disease with poor prognosis. So these are the importance of the myositis antibody. Yeah. So next, I would like to talk about the one of the most well described subgroup. Okay, the anti-synthetase syndrome. So for this anti-synthetase syndrome, so first the anti-synthetase antibody must be positive together with all these features. Where the major features include ILD and also of course the myositis, and minor features include arthritis, Raynaud's phenomenon, and also the mechanic's hand. Yeah. So what do we mean by mechanic hands in the anti-synthetase syndrome? It's also another typical type of rash, okay, where it is described as a hyperkeratosis, scaling and fissuring on the lateral surfaces of the fingers, particularly the ulnar surface of the thumb, okay, and the radial surface of the other finger. Okay, so this will actually give the typical rash, the V-shaped rash, okay, where we call it a mechanic's hand. So next, I think we move on to briefly on the principle of management of the inflammatory myositis. Okay, so we based on the American Society criteria, by the ACR, published in 2021. So the management include actually can be divided into non-pharmacological and pharmacological, where the non-pharmacological include exercise program, physiotherapy, occupational therapy, speech therapy, sun avoidance, and also the uh, vaccination for those who has the lung disease. Pharmacological treatment will be based on the organ involvement and also the subgroups. Okay. Yeah. So based on this ACR guideline, the first line pharmacological treatment of the myositis will be steroid together with AZA or methotrexate. Second line include mycophenolate mofetil (MMF) or calcineurin inhibitors, which include cyclosporin or tacrolimus, or combination of methotrexate and also azathioprine. Okay, third line involve those more advanced therapy for example, rituximab, cyclophosphamide, IVIG, abatacept, which is the T cell inhibitor, tocilizumab, IL-6 inhibitors, and also the newer agent, the JAK inhibitors. Yeah. So I think enough with the theory part. So next we move on to the more interesting case illustration. So we have case one. We have this 36 years old female, A. stewardess. She first presented to us with bilateral upper limb and also the lower limb weakness for 1 month duration. Okay, associated with bilateral thigh pain, which caused her to have frequent fall at the workplace. There was also dysphagia and also constitutional symptom as well. So on examination, there was tenderness over the bilateral arm and thigh region, proximal muscle 3/5, distal muscle 4/5, and there was arthritis over the bilateral knee. Swallowing test failed, okay, but there was no rashes. The muscle enzymes are all raised, the AST, ALT, and CK were raised. Yeah, so with that, she was actually and there's no history of any medication consumption, and there's no strenuous exercise. So with that, actually, we're treating the patient with the idiopathic inflammatory myositis with dysphagia. So she was admitted to the ward and was given IV metopred 500 mg OD for 3 days. Yeah, and her proximal muscle weakness actually improved to 4/5, but the dysphagia persists. Okay, so with that, we have decided to give her IVIG 0.4 gram per kg per day for 5 days, because there's some positive result and evidence of IVIG on the symptoms of dysphagia in myositis patient. So subsequently, the myositis panel came back, the anti-Jo1, anti-CM1A, and the anti-RO52 were positive. And MRI bilateral thigh show heterogeneous patchy contrast enhancement over the bilateral thigh muscle consistent with the inflammatory myositis. Initial malignancy workup were all negative. Yeah, she showed good response to our steroid and also the immunosuppressant treatment. She was initially started on azathioprine, but she had a flare while on azathioprine. Hence, we decided to put her on the combination therapy of azathioprine and also the methotrexate. Her prednisolone we are able to cut down to 10 mg OD, and we plan to further taper off after this. And she did very well. She recovered well and back to her work at the moment. Yeah, so I think here we have this our first Slido question. Okay, I think for those who log in using the laptop, you can scan using your phone. Okay, so the question is will you proceed with muscle biopsy in this case? Okay, I'll give around 30 seconds to 1 minute for you all to scan and give your answer. Good, good. We have quite a lot of responders. Okay, I think I think 50-50. 50% think they will proceed with muscle biopsy, 50% think they won't do the muscle biopsy in this case. So when to perform muscle biopsy in myositis, if we suspect myositis. So is there any guideline to guide us when to do the muscle biopsy? So the answer is there's no official recommendation. So so mainly the whether to proceed with the muscle biopsy, it depends on the case-to-case basis, and also depends on the treating clinicians. But I found this paper, there's one this paper published by the Australian, just published last year, where they did an international survey on the muscle biopsy practices in the myositis in treating the myositis patient. So mainly involve the clinician, the neurologist, and also the rheumatologist. So they find out that in this situation where there's abnormal MRI and also abnormal EMG, together with the negative myositis antibody, they are more the treating clinician, they are more keen to perform the muscle biopsy. Whereas if let's say there's already classical cutaneous features of dermatomyositis, together with the positive myositis antibodies, the treating clinician, they are more inclined to perform the muscle biopsy because it won't give the extra information. So other factors that we should consider also include the service availability. Okay, for example, in our center, Hospital Seremban, because to arrange for muscle biopsy is not that simple. Okay, so for example, in our center, we will need to refer to our orthopedic surgeon, okay, to help with the muscle biopsy. Then we will need to call up the histo lab in HKL to arrange the transport, make sure that we send it in the maintain the cold chain. Okay, make sure that we send the make sure that you receive the fresh sample from us. Okay, so that they can give a good report on the muscle biopsy. So other consideration include patient preference and also the whether there's a presence of comorbidities or not. Okay, so for this case, the above case, we have decided to proceed with the muscle biopsy. First, because initially there was some delay in response to the initial treatment, and also there is some discrepancy from the antibody profile with the clinical features, because the CN1A is positive, but there's not much of the distal muscle weakness. So there's some discrepancy. So for this case, we decided to proceed with the muscle biopsy, where the muscle biopsy come back to show myopathic changes with the passive perivesicular necrosis and regenerating process. Okay, and for the immunohistochemistry, the MHC1 and MHC2 come back to be strongly positive. Okay, so together with this IHC staining and anti-Jo1 positivity, so it's suggestive of the anti-synthetase syndrome. So these are the muscle biopsy findings, okay, that we'll find in different subgroup of myositis. That how muscle biopsy will help us. Okay, okay. If let's say there's a if that okay discrepancy of the clinical features with the myositis antibody. Okay, and also it helps us to subclassify our inflammatory myositis. Okay, so done with the first case. So we proceed with the case two. Yeah, so case two, we have this 43 years old female teacher presented with reduced effort tolerance and chronic cough for 1 month duration. She actually presented initially to our recipe colleague where they did a HSLCT where show organizing pneumonia changes over the bilateral lower lobes. Anti-Jo1, anti-Q, anti-Ro52 were positive. Then she was treating as a myositis-related ILD or IPEF. She was given IV metopred 500 mg OD for 3 days. And she was started on MMF and tapering dose of, subsequently she was started on MMF and tapering dose of penicillin. She, at this point of time, she's still oxygen dependent, okay, with around, we require around 3 liters per minute oxygen. Then 2 months after that, she started to have macular papular rashes over the face, upper limb, and the lower limbs. The rashes was not photosensitive and non-itchy. So because of the area of the rash, okay, it's not the typical rash that I showed just now. So there's some concern about the possibility of the drug eruptions. So hence the MMF was withheld. Okay. Then subsequently, we have referred this case to our dermatology colleague, where they did a skin biopsy, which shows interface dermatitis consistent with dermatomyositis. So with that, the MMF was we started back and the dose optimized to 1 gram BD. So this is the rash of the patient. You can see actually mainly involve the lower limb, upper limb, and the rash is not the typical rash that I showed just now. Yeah, so from this picture, yeah, you can also see actually this patient is a very good patient. She's very compliant to the medication. And yeah, so from here you can see actually all the typical facial features of the Cusingnoid syndrome. Yeah, so with the MMF, she did very well. She responded very well, and she's no more on oxygen. And the lung function test shows stabilization, and the HLCT also show improvement in terms of the ground glass opacity and also the OP changes. Her MHA has improved from class 3 to class 1 to 2. Yeah, and her penicillin, we are able to taper down until 4 mg OD in May 2025. Unfortunately, okay, she started to have reduced effort tolerance, okay, in June 2025, okay, where her NIHA class became class 3, and there was desaturation, and once again she became oxygen dependent. Yeah, so she was admitted to the ward again, okay, with repeated HLCT show worsening reticulations, traction bronchiectasis, and also ground glass density, particularly in both the lower lobes. And there's now new left lower lobe volume reduction. And once again, she was given IV metopred pulse, okay, for 3 days. And after discussion with the family members, we started the patient on the IV cyclophosphamide monthly, and we aim for 6 cycles. So this is the lung function test for the patient. Yeah, so you can actually see there's a actually improvement of the lung function test, okay, where she responded well to the MMF. There's an improvement in terms of FEV1 and also the FVC, okay. But subsequently, there's a deterioration of the FEV1, FVC, okay, in correlation, okay, with the we correlate with her clinical deterioration. Yeah, so these are the HRCT images. So yeah, this is the first HRCT image, okay, before she was started on treatment. So from here you can see actually there's a lot of perilobular and also peribronchovascular opacity seen, consistent with the OP changes. Quite a bad one. Yeah, then subsequently, this is the second HRCT where after the initiation of the MMF, so you can see actually improvement in terms of the OP changes and also the ground glass opacity. So this is the latest HRCT. Okay, yeah. After she complained of worsening symptoms, yeah. So from here you can actually see there's a worsening of the ground glass opacity and also the worsening reticulation as well. Yeah, so for this case, I just want to show that some patient, myositis patient, they might not initially presented with the muscular cutaneous features. Okay, yeah. For example, for this patient, actually, there's not much of actually there's no muscle weakness. Okay, and the cutaneous feature actually come after the respiratory symptoms. Okay. Yeah, so so for this patient, actually, we can classify the patient to have this clinically amyopathic dermatomyositis, CADM with ILD. Okay, so I think we move on to our last case. Okay, yeah, so we have for our last case, we have this 70 years old Chinese lady underlying dyslipidemia, presented with reduced upper tolerance and cough for 2 months duration. There was also proximal muscle weakness and rashes for 1 month duration. There was also dysphagia and also hoarseness of voice. So yeah, from here I want to stress on like for those patients, if you I mean during the initial diagnosis of the myositis or during the follow-up cases, okay, other than assessing the muscle power, is also I mean very important for us to assess the bulbar muscle I mean the involvement. Okay, for example, we can ask about dysphagia and hoarseness of voice, because this is important because the presence of the bulbar muscle involvement is actually indicates severe disease, okay, and actually an indication for admission, and also the is an indication for us to intensify our treatment. Yeah, so yeah, this one is the rashes that this patient has. Yeah, so very typical rashes, very nice rash. Okay, you can see over the knuckles. Okay, yeah, this is the V-shaped sign that I mentioned just now. Yeah, she's non-smoker, non-alcoholic, no family history of malignancy. Myositis panel come back, anti-MDA5 positive, anti-Rho52 positive. CT thorax, CT thorax show ground glass opacity with interstitial thickening over the bilateral lower lobes. Yeah, so remember 70 years old lady, dyslipidemia, present on dysphagia, hoarseness of voice. Myositis panel, anti-MDA5 positive, anti-Rho52 positive, and there is a presence of ILD. Yeah, so my next question is, what do you think is the myositis related malignancy risk in this patient? So whether it's a high risk, whether it's an intermediate risk, or is it a low risk? Yeah, so I think you all can scan and give your answer. Okay, so I think most of the thing is a high risk. Okay, yeah. Okay, so yeah, yeah. So as we all know that actually we know the inflammatory myositis actually is associated with malignancy. Yeah, so but do we have any guideline to guide us how frequent or how extensive we should do our cancer screening on this type of patient? Yeah, so next I would like to talk about this guideline by the IMAX initiative, okay, where they published this in 2023. It is a international guideline for cancer screening in the inflammatory myositis patient. Yeah, so under this in this paper, okay, so first, if let's say you need to diagnose inflammatory myositis within 3 years of symptom onset, if let's say it's a juvenile onset, okay, cancer screening is not routinely required. If let's say it's an inclusion body myositis, cancer screening is also not routinely required because they are actually not found to associated with malignancy. But if let's say it's a adult onset, okay, so we need to do the risk stratification. So the risk stratification include based on the subtype. Okay, for example, if let's say the subtype is dermatomyositis, okay, then it fall under these high risk factors. Okay, and also based on the myositis antibody. Okay, if let's say those anti-TIF1, anti-NSP2, they are fall under these high risk factors. For clinical features, if the age of onset more than 40 years old, elderly onset, persistent high disease activity despite therapy, presence of dysphagia, cutaneous necrosis, all these are actually under these high risk factors. These are the intermediate risk factors, and these are the low risk factors. Yeah, so after we go through all the clinical features and also the myositis antibody, so if let's say the patient has more than or two high risk factors, we will fall under this high risk group. Okay, so for high risk group, at the screening at the time of diagnosis, we will need to do the basic and also the enhanced screening panel. Okay, then the screening and follow up, we need to repeat the basic screening panel at year 1, year 2, and year 3. Okay, then for those patients with additional risk factors, okay, or also symptoms, we might need to consider upper and lower scope and also the PET scan as well. Then for those who fall under this intermediate risk, okay, screening at time of diagnosis, basic and the enhanced screening panel, and there's not necessary to repeat the screening and follow up. If they say it fall under this low risk group, okay, at time of diagnosis, we just need to do the basic screening panel, and there's no necessary for us to repeat and follow up. Here, I just want to emphasize that at our geographical area, okay, Malaysia, okay, where the prevalence of the nasopharyngeal carcinoma is very high. So yeah, so in our region, we might need to consider to refer the cases of myositis to our ENT colleague for screening of the NPC. Yeah, so go back to our patient, the case 3 just now. So what is the risk of the patient? Okay, so she has dermatomyositis. Okay, so fall under high risk factors. She has anti-MDA5 under the intermediate risk factors. Age of onset, more than 40. Then there's presence of dysphagia. Okay, so there's there are three high risk factors. So she easily fall under the high risk group. Okay, so for this patient, while we are treating the dermatomyositis, okay, we will need to do a thorough malignancy screening for her. Yeah, so I think this is my last slide. Okay, take home messages. Serological profiling has actually shifted the paradigm of the myositis classification and also the diagnosis. And muscle biopsy is not necessary or compulsory in cases with typical presentation and positive myositis antibodies. And risk stratification is very important, okay, in cancer screening in myositis patient, so that it can help us, to decide how far or how frequent should we screen our patient for malignancy. So with that, I thank you.
Thank you, Dr. Chuck, for the wonderful talk. I think Dr. Asma is having some problem to join us, so I think we will move on to the Q&A session. So, to all the participants, if you have any question, kindly type your question in the Q&A box or the chat box. So we have a question from one of the participants. Recently, a dermatologist in Singapore was suspended for 14 months because he failed to inform patient of possible serious side effect of azathioprine and failed to screen for poor metabolizer of azathioprine. So is the screening done routinely in Malaysia before treating patients with azathioprine?
Yeah, I think at the moment, yeah, so far in Malaysia, I think we have not practiced to screen okay to do the screening, okay, for all the patients we started on azathioprine, okay. But of course, we'll inform the risk factors, okay, to the patient and document out properly in the case note, okay. And also, we'll usually check the blood, okay. Like for example, we repeat the ABC also and also the liver function test 2 weeks after we started the patient on azathioprine, and also if any increase of the dose of aza, we also to repeat the blood, okay, to make sure that I mean it won't cause any myelosuppression or any other blood abnormalities. Dr. Asma is back.
I'm sorry, but I think something wrong with my all right. Sorry, I think something wrong with my my line that we get disconnected. Yeah, I agree with you. As for thiopurine methyltransferase (TPMT), we don't widely send in our practice. But if in your center, in your clinic, or your patient can't afford to send, just find out where the lab that we can send it to, and by all means send it. But like what Dr. Lehot mentioned just now, we be very careful. We discuss with the patient as well as we repeat it after 2 weeks or something like that to make sure the parameters are all okay. Okay, there's another question, Lehot from Lingore. Hi, Gore. How relevant of the other serological test positivity, i.e. Rho, etc., together with the myositis panel? How does these results change your management? Like,
Thank you.
yeah.
Thank you, Dr. Ling, for the questions. Yeah, I think as you know that anti-Rho is actually associated with the I mean it will be positive in the patient with myositis overlap with other syndrome, and anti-Rho positive itself actually patient has a higher risk of ILD. Okay. Yeah, so yeah, then those with the Rho positive patient, then I think we will need to ask the patient about the respiratory symptoms, okay, and do a clinical examination, and if let's say there's a suspicious of ILD, we should proceed with HSLCT and anti-Rho also. Yeah, if let's say the patient, myositis patient with Rho positive patient, get pregnant, I think we need to, uh, discuss with the ONG colleague, okay, to screen for the congenital heart block.
Yep. Actually, to me, the myositis-specific or associated autoantibodies, it is important when there is additional symptoms that strengthened and clinch the diagnosis and tell you whether you're going to treat this more aggressive or not. In particular, MDA5. You know, MDA5 with myositis, IIM with MDA5, they can have a very bad interstitial lung disease that necessitate double, triple therapy at the same time rather than wait. But at the same time, if the patient has no clinical features suggestive of other associated disease or other complications, with the presence of the autoantibodies, it helps us in monitoring. keep asking, and then whenever we see the patient, we look up for all these signs and symptoms. For example, those patients with anti apa yang malignancy tu anti-me, yang ada association dengan malignancy, then you have to keep looking for clinical evidence of malignancy. Yeah, any other questions?
There are some questions in the Q&A box.
Q&A box. Okay, hold on. Q&A box. I punya tak dapat lah the Q&A box. So sorry,
It's
Kelvin.
okay. I will read out the questions.
Yes, please. Thank
Okay,
you.
the first question, would you consider lung transplant in these patients if antibodies are positive and medical treatment doesn't help?
Yes. I mean, yeah. So, for treatment of ILD, actually, as I mentioned, we got the first line, second line, and third line, and also, then, for those with severe refractory one, then we might consider the third line therapy, like all those I mentioned before, the MDF5, ILD. Usually, they are very severe and very progressive one. Yeah, and their response to the treatment might not be or they might progress even with the treatment. So if let's say for those patients who are refractory to treatment, lung transplant is actually definitely one of the choice. Okay, but I think there's selection of the patient, a specific selection criteria for the patient under our recipe colleague. Okay, so for those patient, usually for those patients with a very prominent ILD involvement, usually we will co-manage with our recipe colleague. And if they think that the lung transplant is one of the option, they will actually refer to the lung transplant team. Actually, they have the specific lung transplant team in the KKM.
Okay, the next question, what else can we offer if conditions still deteriorate despite given methylprednisolone, IVIG, cyclophosphamide in patients with polymyositis and ILD?
Yes. Yeah. So I mean, the question is, I mean, all those patients who is not responding to the treatment. So I think, for myositis patient, who is not responding to the treatment. So I think there are a few things that we need to be in our mind. So first, I think is if let's say patient admitted in for the IV methotrexate, usually they have no issue with compliance. But if let's say patient treated as outpatient, so first we need to make sure patient is compliant. So we check the compliance of the patient. Second, as I mentioned before, if let's say we're refractory to our treatment, we might need to revise our diagnosis, okay, whether our diagnosis is correct or not, okay. So sometimes I think certain patients, they might label to have certain type of muscular dystrophy, yeah, but after that, actually, we find out that actually they are having myositis, and they are, I mean, after we give the immunosuppression, they are very responsive to the treatment. Then thirdly, I think if let's say we're refractory to treatment, we need to I mean, screen for malignancy, okay? Like all those elderly patients, okay? They have, I mean, if let's say they have underlying malignancy, so at the same time, when we're treating the myositis, we should also treat the underlying cause, underlying malignancy as well. So I think these are the few things that we need to, sit back and think back when, if the patient is not responding to the treatment we are giving.
Okay, the next question in the chat box. Is late onset vasculitis similar to late onset lupus that we should look hard for malignancy? Do they have high mortality compared to younger patients?
Okay, so I think I go to the late onset vasculitis first. Yeah, I think vasculitis, yes, I think if let's say the elderly onset vasculitis, okay, definitely we will need to screen for malignancy. Okay, I mean we should ask for any signs and symptoms for malignancy. Okay, and screen hard for that. So yeah, then for late onset SLE, yeah, as you all know that SLE patient usually they are young patient. And also particularly for SLE, let's say juvenile onset SLE, usually they are the type who has a poor prognosis one. Okay, young onset SLE, usually they are more aggressive. they are more difficult to treat and associated with the higher risk of flare and also higher risk of complication. Compared to those like adult onset. Yeah.
Okay. I don't have any other question here. Kelvin, do you have any question?
All right,
Dekat sana?
there are a few more questions.
Oh,
For your case 3, she has dyslipidemia, presumably on statin. Do you routinely withhold statin for patients with myositis?
Okay, so yeah, very good question. So I think I think now we are talking about the statin induced myositis, okay, which is the HMG CoA reductase associated. But I think we for the case 3, I think for this kind of case, I think we need to find out the temporal relationship between the onset of the symptoms. If let's say whether the patient was initially started on, whether it's like happened after the patient was newly started on statin or not. But for the case 3, a patient is already on the statin for very long already. Yeah, and also I think common things still compass. If they say you have patient on started on statin, they come in with some myalgia or some ache over the muscle. Usually our practice is that we will just we hold the statin, okay, then observe the symptoms. We don't even will send all the muscle enzyme all this lah, because I think the statin induced myositis is still it is not common, okay. So yeah, we still we won't straight away, go to jump into the analysis of the statin induced this inflammatory myositis first. So usually we'll off the statin, then we'll observe, then if the symptom very severe, then only we'll think of to send off the other the further investigation for the patient.
Okay. The next question: are there any biologic agents available for myositis at the moment?
Yeah, I think just now in my slide I do show the third line therapy. Third line therapy, which include the rituximab, the JAK inhibitors, and also the tocilizumab. Yeah, all those these are the newer agent, the biologic agent. JAK inhibitors mainly we use for the anti-MDF5 associated ILD. There's data on that. Yeah.
okay. There's another 2 question here in Q&A. Okay, for refractory or difficult to treat, is this question answered already?
I
Not
think
yet,
this
right?
is
For the new question, right?
Yeah.
Because just now I couldn't open my Q&A. Sorry. If for refractory or difficult to treat IIM ILD like anti-MDA5, we basically need to throw the kitchen sink at them. Repeat courses of IVIG, abatacept, tofacitinib, tacro, often in combination. Consider ECMO in the extremes while await immunosuppression to work. Agree. I answer for you, Leho, because
Yeah.
I agree. MDA5 with ILD is no joke.
Yeah,
We
we
have
really need
to
to act
go all
very fast now.
resources to help them. Yeah, we have to go all resources to help them. Hi, if patient has reduced effort tolerance without initial rash or weakness, what is the basis investigation that usually leads us towards dermatomyositis? You
Okay,
know,
means that patient only has reduced effort
lah.
tolerance. Yeah. Okay, I think we should still go clinically. We ask for any other symptoms. Okay, we check the patient thoroughly. Check the lung. Okay, look for any fine crepitation. Then if let's say there's I think basic screening with the chest X-ray will help us. Okay, and also if let's say your center has a lung function test, we can also do a lung function test. Yeah, then if suggestive of ILD, then probably we can arrange for HRCT.
Yeah. So for case 3 just now, the lady, no, the other one, already confirmed inflammatory myositis. Can the statin be restarted?
For which for case 3, is it? Yeah. Okay. Yeah, actually if let's say we think it's not due to the statin, okay, then usually after we treated the patient, if let's say the liver enzymes they are all okay already, I think should be okay for us to start. But all those patients we think is the statin induced myositis, okay, with the HMG CoA reductase positive. I think I think it's safer. For us not to restart back the statin. Yeah. Mm.
Yeah, right. So another question in the chat box, one of the possible reasons for muscle complaint is using combination of high doses of amlodipine and simvastatin. I think this is a comment by one of our listener. Yes, agreed. So that's why before we even include the patient in the equation of idiopathic inflammatory myositis, we must rule out possible other causes. If there is possible other causes, is this not idiopathic anymore? Then we have to go, Then if we can't find any obvious causes, then it may classify this patient into the idiopathic inflammatory myositis and follow what are the associated symptoms, signs and symptoms and investigation result. Okay, any other questions? Do you have any other question from your side, Calvin?
No.
I don't have any more questions on my side. If no more questions, I think we have already reached 4 o'clock. Thank you. I think we shall end this session. Thank you, Dr. Chok. I think this is all the time that we have for now. Thank you, everyone, for listening and all the questions that are posted. Very relevant, very practical question. And we also appreciate all the comments and advices that we get from our listeners today. I hope we all manage to refresh as well as gain new knowledge to also assist us in our practice. Myositis is not that rare, actually. Keep on the lookout. If no obvious primary cause, may consider idiopathic inflammatory myositis. Do discuss with the rheumatologist nearby and refer to us. Thank you, Dr. Cho, again, for the informative talk. Thank you, Academy of Medicine, for giving us a chance to share. Don't forget to tune in again on the 14th of August, same time for another interesting rheumatology topic. That is vasculitis. Vasculitis unveil a practical approach for the frontline clinician. With that, we say thank you and goodbye. Thank you very much.
Goodbye.
Thank you.
Thank you.